Welcome, ladies and gentlemen. I'm Dr. Silva, and today you're in for a treat. I'm going to talk to you about Schizoid Personality Disorder, which is one of the lesser known personality syndromes. Most people probably never heard of it. And as a matter of fact, it's rare in clinical practice. I've never seen a case, and I think it's because these individuals typically don't present for treatment. And since they don't bother anybody, friends and family and associates are also not rallying around to bring this person in for treatment. Maybe they're seen as children. Parents may take them in, but I'm not a child psychiatrist, but they're not common in clinical practice. And so just a word on the current nosology. Right now, the DSM, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, uses a categorical perspective. The idea that personality disorders are qualitatively distinct from one another. They are distinct syndromes that are grouped into clusters. An alternative view is the dimensional perspective, which states that the personality disorders represent maladaptive variants of personality traits that merge imperceptibly into normality and into one another, and also other psychiatric conditions, i.e., they are a spectrum of severity. And that's a very trendy phrase right now. When people say, I'm on the spectrum, they're alluding to autism, because autistic disorders, Asperger's disorder, have now been renamed autism spectrum disorder. So that encompasses everything from mild Asperger's to more severe autism. And now it's very trendy for people to say they're on the spectrum. When we say, oh, I'm on the spectrum, we're alluding to autism. However, there's also a psychotic spectrum, and you could talk about a spectrum of mood disorders. What you're saying is that it's one illness, it's one condition, one pathophysiology, one disease process that when it's mild looks like one thing and we call it one thing, and then as it progresses in severity, you see more severe symptoms, but you also see other symptoms, and it's really the same illness. So I like that model better. Schizoid personality disorder could be considered, it actually is on a spectrum with schizotypal personality disorder. They overlap a lot, but schizotypal is more severe. Schizotypal, you actually see psychosis, whereas in schizoid personality disorder, you really don't see psychosis, but you do see affective flattening that can be a harbinger of psychosis, and then schizophrenia in the further extreme. So there is a psychotic spectrum as well. There are many disorders, delusional disorder, lots of disorders, but just talking about these three, there is a schizoid personality that is typically not psychotic, although that person may be slightly more prone to brief psychotic episodes than other people. And there is affective flattening, which is often a harbinger, but really there's no psychosis. Then you have schizotypal personality disorder, which if you consider that to be the same illness, but just further along, you do see psychosis, odd thinking, magical thinking, eccentricities, not just the affective flattening and the social isolation. And then schizophrenia, which is obviously an actual primary psychotic disorder with a poor prognosis. It's a degenerative condition. And those syndromes overlap. They bleed into one another. As a matter of fact, when an individual develops a persistent psychotic disorder, for example, schizophrenia, that was preceded by schizoid personality disorder, the DSM states that schizoid personality disorder should also be recorded, followed by quote-unquote pre-morbid in parentheses. Just like with paranoid personality disorder, when it develops into schizophrenia, we call it pre-morbid paranoid personality disorder. But really, it's part of the prodrome of schizophrenia. It is actually the same illness that was just getting started. And so I don't know why the DSM says that you should diagnose both conditions. They're being very strict about, well, you met criteria for this condition, so this is what we're going to call it here. Then you meet criteria for this condition, and this is what we're going to call it here. But that suggests that they're two different illnesses, and they're not. They're the same illness. Now, these are syndromes, so we're not saying that schizoid personality disorder in one individual is the same condition as schizotypal personality disorder or schizophrenia in another individual. They're syndromes. They're constellations of symptoms. We don't know what the etiology is, the root cause or the pathophysiology, the disease process. And it could be different in one individual versus another. Just like major mood disorders, one person with bipolar disorder could have a different root cause and a different disease process than another individual with bipolar disorder, even if they have many of the same symptoms. The same is true here. You can have two individuals with schizoid personality, but they don't necessarily have the same illness. However, in any given individual, if they start out schizoid or schizotypal, but they end up schizophrenic, that person doesn't have 2 or 3 conditions. They have one condition. That's the same illness, folks. That's the same illness that was just getting started and that just got progressively worse. It would be, I think, naive to presume that just because of the current nosology, the way we categorize disease and how we name disease for research purposes, that we're going to say they were different conditions. The DSM clusters personality disorders into 3 categories. Cluster A, odd, eccentric, quote unquote, weird. Cluster B, dramatic, emotional, quote unquote, wild. And cluster C, anxious, fearful, quote unquote, worry. And these groupings, they are grouped together because they share a lot of the symptoms, a lot of the same symptoms. But that doesn't mean that they share etiologies or pathophysiologies. And the DSM admits that they might also be viewed as dimensions, representing spectra of personality dysfunction on a continuum with other mental disorders. And that's my preference. That's how I like to think about it. So I could do one video on schizoid/schizotypal personality disorders, but I'm going to go ahead and divide this up so that it can be better digested by people who don't really want to sit down for a 40-minute lecture. But please stay tuned for part 2, schizotypal personality disorder. And while they are 2 distinct syndromes, it's just a different variant of a primary psychotic disorder that maybe has different genetic antecedents and different epigenetics, but they're all in the same ballpark. They're all the same syndromes. Maybe. We don't know. We don't really understand the etiology and the pathophysiology of these conditions. But I'm saying that it is worth having distinct lectures because they are distinct conditions. They do overlap a little bit. They do bleed into one another. So stay tuned for that. But here is schizoid personality disorder according to DSM-5-TR. Criterion A. All individuals must meet criterion A, which states that the core dysfunction in a person with schizoid personality disorder is a pervasive pattern of detachment from social relationships and a restricted range of expression of emotions in interpersonal settings, i.e., detachment and affect. The affect is the way that a person expresses emotions. It's largely facial expressions, it can also be body language, and it's the voice, the tonality, the inflection. So a blunted affect, you would see a restricted range of facial expressions and expressed emotions. An affect can be labile, it can be unstable, it can be inappropriate, incongruent with speech. A person is laughing when they're describing a traumatic event, and there are different reasons why that might be. Or it can be restricted, blunted, or flattened. And that's also a spectrum. And it suggests psychosis. I'm going to go into that in a little bit. But you also have the requirements that these symptoms begin by early adulthood and they're present in a variety of contexts. So just like all other personality disorders, they don't develop in middle age, and you don't just see it at work or at home. You don't just see it in the context of this or that relationship. It's across the board. And you are required to have 4 out of the following 7 criteria. But in the real world, of course, I'm not going to not diagnose it if a person merely satisfies 3 of these criteria, if in my best clinical judgment and looking at the individual overall, I feel strongly that he or she does in fact suffer from this condition. Number 1, neither desires nor enjoys close relationships, including being part of a family. These individuals appear to lack a desire for intimacy. And really they have a diminished capacity. They're disinclined to have close personal relationships, even with first-degree relatives, even with parents or siblings in most cases. And they seem to have less of a need for it. This is an interesting thing about this disorder, is that a lot of the diagnostic criteria begin with the words seem and appear to. Now, these individuals have been studied, they've been interviewed, but they're so hard to relate to, and they in fact don't relate normally to other people, so perhaps the answers they give aren't very satisfying because the diagnostic criteria are they seem to have this, they seem to be feeling this or to be feeling that. It's like we don't fully understand them. And so we say that there is a lack of a desire for intimacy. They're loners. They're pathological loners. So you do see behavior and they don't seem bothered by it. They don't seem lonely. They don't complain of it, certainly. But it's not really clear whether they actually lack this desire or whether, like autistic individuals, they have a really impaired ability and so they take the path of least resistance. But they seem indifferent. There's that word again. They seem indifferent to opportunities to develop close relationships. And they don't seem, I'm quoting here from the DSM, they don't seem to derive much satisfaction from being part of a family or some other social group. This is unlike persons with avoidant personality disorder or social anxiety disorder for that matter that are inhibited. They want to have friends and to have relationships, but they're extremely anxious. And this is not the case with individuals with schizoid personality disorder. Number 2, almost always chooses solitary activities. They prefer spending time by themselves rather than being with other people. And again, this is not because they're worried about how they're going to be perceived or judged, or they don't know what to say. They may not know what to say, but it just doesn't occur to them. They have this incapacity to relate in a normal manner. And that's probably linked to the fact that they don't necessarily seek it out. Again, they seem indifferent. So they appear, again, I'm quoting for the DSM, appear, seem, they appear socially isolated. They're loners, and they almost always choose activities or hobbies that don't include interaction with others. So they like mechanical tasks, abstract tasks. They maybe spend a lot of time playing computer games or mathematical games. It goes along with how they're hardwired. Number 3 and number 4, has little, if any, interest in having sexual experiences with another person and takes pleasure in few, if any, activities. Nothing is said about the masturbatory activity of these individuals, so we don't really know about their libido. There's really no evidence or no documentation that there's something wrong with their sex drive and they don't have a sex drive. But in terms of coupling with another person, in terms of intercourse, you do see what seems to be an indifference or a decreased need because they don't seek it out. And again, it's not because they're anxious. There is a statement in the DSM that there is usually a reduced experience of pleasure from sensory, bodily, or interpersonal experiences. And the example that's given in the DSM is walking on a beach at sunset and or having intercourse. So those are two pretty widely separated examples, but because of their lack of social skills and their lack of a desire for sexual experiences, individuals with this disorder have few friendships, they date infrequently, and they often do not marry. Unlike individuals with social anxiety disorder or avoidant personality disorder, who have a lot of difficulty initiating new friendships, but most of them do end up being married, and then within the context of that relationship, they're able to relax a little bit more. Maybe not entirely. Persons with avoidant personality disorder have been known to continue to be socially inhibited. I just did a video on avoidant personality disorder. Please check it out. Occupational functioning may be impaired in these individuals, particularly if interpersonal involvement is required, but individuals with this disorder may actually do well when they work under conditions of social isolation, and they're prone to choose that category of work. They gravitate toward those jobs. Persons with schizoid personality disorder take pleasure in few, if any, activities other than just sex. And so maybe with the exception of computer games, which I've mentioned, this is actually the definition of anhedonia, the inability to derive pleasure in normally pleasurable activities. And that's a depressive symptom. So that's in the differential. We definitely have to rule it out. These individuals do develop major depressive disorder, and so they need to be evaluated for that. But it can be difficult because of this, what looks like anhedonia, what is defined as anhedonia, but is not necessarily linked with a depressed mood. In fact, the exclusion criteria of this disorder, criterion B, says it can't be due to depression. You don't call it schizoid personality disorder if what it really is a major mood disorder. But it can also be difficult to rule out depression in these individuals because of this chronically flattened affect. Because that's also a symptom of depression. The affect starts to become constricted. It starts to become blunted when a person is depressed. And when a person gets really bad news, they could be so shocked that they're not responding, they're in a daze, and then that wears off. If that is present day after day, week after week, then it's almost always a major mood disturbance, major depression or bipolar depression. But these individuals are always kind of a little flat. And so you have to rule out mood disorders when they're not socializing, they're not taking pleasure in things, and their lives sometimes seem directionless, and they may appear to, quote unquote, drift in their goals. Number 5, lacks close friends or confidants other than first-degree relatives. That would be family of origin relatives, parents and siblings. But remember symptom number 1, the patient neither desires nor enjoys close relationships, including being part of a family, typically. Number 6, appears indifferent to the praise or criticism of others. This is opposite of avoidant personality disorder, in which that fear is hypertrophied. Avoidant personality disorders are absolutely terrified about other people judging them because they feel inadequate. The individual with schizoid personality disorder, it probably just never occurs to them whether they're inadequate or not, but they do not appear to be bothered by what others may think of them. It's not why they isolate. Number 7, shows emotional coldness, detachment, or flattened affectivity. So here we have two things. We're talking about two things. We're talking about a restricted or blunted affect, which implies that they are not feeling anything, that they are aloof, that they're emotionally cold. But this could actually be just a misinterpretation. When you see someone who's kind of in a monotone and they're just kind of looking at you, they don't smile, and they're not nodding and smiling, they're not responding appropriately to social cues, a lot like autistic individuals. They seem socially inept or superficial and self-absorbed, i.e. aloof. But I suspect, given my understanding of this disorder, I suspect that sense of aloofness, which is really more of a conscious thing when people are emotionally cold and they don't care about you, and they're not being warm, and they're not making eye contact, and they're not inviting in terms of their speech and their demeanor. That's aloofness, and there are lots of causes for that, including narcissism. But I think these individuals are just clueless. I think it just doesn't occur to them, and it only seems to other people, including the people that wrote the DSM, the committees of clinicians that have discussed this and researched this condition. They say that people seem aloof, but that might not be true, because when you see this quote-unquote bland exterior without visible emotional reactivity in these individuals who rarely reciprocate gestures or facial expressions such as smiles or nods, you're talking about their affect. And they could be depressed, for one thing, or they could be psychotic, as I said before, because the constriction of the affect, it doesn't always indicate psychosis. It could indicate just severe depression on the way, perhaps, to psychosis. But these individuals have this chronic affective blunting, and they are prone to brief psychotic episodes, but the majority of them don't experience that. And psychosis is not part of the diagnostic criteria, unlike schizotypal personality disorder. And so here's another spectrum. You see it in major mood disorders. You see it, most commonly, you see it in major depression or bipolar depression, where the individual is beginning to get sick. And this does imply, by the way, that there is endogenous illness, that there's a problem in the central nervous system with the neurotransmitters. It is a chemical problem. Because when a person gets bad news, maybe they're getting divorced or someone died and they're in grief, they might show, when they're in shock, initially, they might show some affective blunting, where they're really not responding. People are asking them questions and they're saying, I don't know, yes, no, and because they are beside themselves. But that might last a few hours or a few days. Here we're talking about every day, all day, for their whole life, really. And that is what you see in this disorder. But in a major mood disturbance, like major depression, you would see it for the course of the illness in some individuals, for a few months, weeks to months, if it's untreated. And what it reflects is that there's a problem chemically, that it's not just an adjustment disorder. They're not just upset because they're divorcing or because they lost their job. And it starts, I called it a spectrum. And so you see it. When it's mild, you call it a constricted or a restricted affect. There are facial expressions, they're not completely monotone, but the full range isn't there. And then if it's more severe, you call it a blunted affect, where definitely they're not expressing, their affect is very restricted, it's blunted. And it's noticeable, and even non-clinicians would notice. They might not know what to call it. They might just say, they seemed a little weird, and not be able to say, oh yeah, they were monotone, they weren't making facial expressions, they weren't making eye contact, they were kind of like a zombie. That is affective blunting. And then when it's severe, you call it a flat affect. It's affective flattening, where they are completely flat. There are virtually no facial expressions, virtually no inflection in their voice, the prosody of their speech. And in my book, that implies psychosis. A lot of clinicians, though, will say flat affect, especially trainees, especially medical students and residents. They will document a flat affect when, in truth, you go and you evaluate the patient, if you're supervising, as I have done many, many times. And yes, the patient's affect is blunted, but it's not completely flat. And no, in fact, the patient is not psychotic. But when I write their affect is flat, then I'm saying they're psychotic. And sometimes affective flattening is the only obvious symptom of psychosis. I've diagnosed psychotic major mood disorders and also primary psychotic disorders on this finding alone in the mental status. But then you probe, and they do in fact have some odd thinking, maybe some delusions, maybe from time to time they've even experienced hallucinations. But their overall behavior is not grossly disorganized, and they're still working, and they're not coming to you spontaneously with these weird thoughts, these delusional thoughts. And so you do uncover psychosis later. Sometimes they deny all of those symptoms, but when you talk to them, you see that their affect is flat, and you know that they're psychotic. And usually the experienced clinician can usually find something in the history, something else in the presentation, the history of the present illness, or why these people are coming to you, or just a few things that they said that were just a little off. They were kind of very idiosyncratic, kind of odd that they said that. It wasn't anything delusional, it wasn't anything overtly crazy, but you tie it together with this flat affect, and you just know as an experienced clinician that that patient is psychotic. And so then the next question becomes, why are they psychotic? How long have they been psychotic? Is this a lifelong condition? Is this a primary psychotic disorder, like mild schizophrenia? Or are they suffering major depression, in which case their mood has been low for quite a while, because people do not develop psychosis due to severe depression overnight. And again, what is it? Is it bipolar depression? Is it major depression? So it's important. One of the conditions in the differential is schizoid personality disorder, where yes, their affect is blunted, maybe it's even flat, but it's because they have this personality disorder. It's because they're always this way. Subjectively, these persons claim that they rarely experience strong emotions such as anger and joy. So they have been interviewed and they don't endorse those emotions, but maybe they just don't know how to endorse them. Maybe when they're questioned, they're so literal, they're so concrete in their thinking, because it goes along with this psychotic spectrum that they're on, that they just don't know how to relay that. Because, quote, in very unusual circumstances in which these individuals become at least temporarily comfortable in revealing themselves, they may acknowledge having painful feelings, particularly related to social interactions. So there is evidence, at least in some individuals with this disorder, that they're not completely indifferent to other people. They take the path of least resistance, but it doesn't mean it's because they don't have a desire necessarily. It may just be because they don't know how. But unlike individuals who really want it but are just too anxious, you don't see this yearning. And because these individuals maybe are a little flat and they don't relate normally to other people, even when they're interviewed by clinicians, they may say no, because that's just the easiest answer. But in truth, it's more complicated, it's more nuanced. Yes, they are feeling things, but they're feeling them differently. The feelings may be blunted, and the individual themselves is not able to process the emotion, maybe to even recognize it, doesn't have the insight. So they go play a computer game instead, because that's what they've been doing since they were kids. That's the path of least resistance. So they may not be as cold as they seem. The point I'm making is that just because they have a zombie-like affect, that doesn't mean that they're not feeling anything, or that they're not thinking about their feelings and processing them in their way. The DSM also states that individuals with schizoid personality disorder may have particular difficulty expressing anger, even in response to direct provocation, which contributes to the impression that they lack emotion. So even when they're angry, who doesn't get angry? I mean, we all get angry. But these individuals may be so zoned out when it comes to expressing emotion because their own brain is not processing it, and they're feeling it, but it just doesn't come out in the way that it does typically. If you look at the bell curve, some people yell and scream, other people are afraid of conflict, most of us are in the middle somewhere. Some people raise their voice, some people curse, some people cry when they get real mad. Everybody sort of has a different way of expressing anger. This is another way of expressing anger that's very muted, and you might not understand that the person is angry, because if they do interface with you to tell you about it, which they're not inclined to do, but if they do, you might not get it. You might not get what they're saying. Criterion B is the exclusion criterion, which states that these symptoms, these 4 out of 7, do not occur exclusively during the course of schizophrenia, a bipolar disorder, or depressive disorder with psychotic features, another psychotic disorder, or autism spectrum disorder, i.e., all of the main syndromes that are in the differential diagnosis. If it's any of those things, then you can't also call it schizoid personality disorder if it only occurs in the context of these episodes. So you can diagnose both schizoid personality disorder and major depression, for example, if when they're not having a major depressive episode because it's episodic, they still have the flat affect, they still have the social isolation, they still have what looks like anhedonia. They're not depressed anymore. They definitely were. Now they're on medicine, they're not. They're better, and they deny it, but they still have it. Then you can say that they have both. But if they only have these 4 out of 7 during major depressive episodes, then it's due to that, and they don't have this condition as well. Also, you have to rule out the physiologic effects of another medical condition, such as, for example, temporal lobe epilepsy. While not a formal criterion like you see in other conditions in the DSM, the discussion unequivocally states that only when these traits are inflexible and maladaptive, and only when they cause significant functional impairment or subjective distress, do they constitute schizoid personality disorder. So this is a criterion really that's a part of all conditions in the DSM. Just some of the conditions have a criterion C that says you gotta have this, but you don't see it with the personality disorders for some reason. And yet you are expected to have this. The prevalence is estimated to be between 1 and 5%. It is uncommon in clinical settings, and this, I think, is because they just don't present for treatment. I've never seen it. Perhaps child and adolescent psychiatrists see it more often. I think the subjective distress arm of this requirement may be difficult to assess because these individuals are pathological loners. They keep to themselves. They're not very expressive. And when you ask them, they may be inclined to deny that they're having any trouble. But if the symptoms are chronic, inflexible, and maladaptive, then even if they're not complaining and no one's complaining, unlike the obsessive-compulsive personality, unlike the narcissist and the antisocial personality types, and even the paranoid personality that bother other people, no one's complaining here typically, unless it's a parent that's taking the child in, because it can start in childhood. It may be first apparent in childhood with solitariness, poor peer relationships, and underachievement in school. These children are different, and so they're subject to teasing and bullying. More likely, you're going to see it develop in adolescence, but it's also going to be subtle. And if it goes on to become schizophrenia or schizotypal personality disorder, then it's one illness that developed into, so it's the final illness, if it's schizophrenia, then that's what it was all along. It was just mild, even though the DSM wants you to call it schizoid personality disorder premorbid. It was part of the prodrome. And so it might start schizoid and develop into schizotypal and stop there, or it might keep going. Also delusional disorder, so other psychotic disorders as well. It may be more common in men. Research studies are conflicting in that. And the differential, first of all, other psychotic disorders. Again, despite the affect, these individuals are typically not psychotic. However, in response to stress, individuals with schizoid personality disorder may experience very brief psychotic episodes. That's actually a diagnosis in the DSM, but we're talking about minutes to hours for these individuals. If it goes on for days, then it's something else. And of course, persistent psychotic disorders like schizophrenia, this condition may appear as the premorbid antecedent of schizophrenia. I don't like that language because it is stating, it's not implying, it's stating explicitly that this is one condition, it's the antecedent to another condition, when clearly it is the same illness. It just got progressively worse. And schizophrenia typically shows up in the early 20s. It typically shows up, really, you could see signs of it, the germs of it in late adolescence, because you start to see this social withdrawal, you start to see the blunting, you start to see cognitive symptoms where they're not doing so well in school. You might see major mood episodes. And they're not hallucinating, and they're not delusional, they're not outright psychotic for a few years, but then they have their first episode, they decompensate, they're hospitalized, and they're diagnosed with schizophrenia, and they have this lifelong condition that deteriorates over the lifespan. It's got a poor prognosis. A high incidence of suicide, of completed suicide, up to 10%. But you're not going to say that they had schizoid personality disorder, which was one illness, and then they had schizotypal personality disorder when they were a little bit older in their adolescence, and that was a different illness with a different etiology, and now they developed schizophrenia. 3 different conditions. It was one condition, obviously one condition. So whatever language the current nosology uses, know that you're treating the same thing. I think in a lot of individuals with schizophrenia, the premorbid conditions, the prodrome, is missed. It's missed entirely. Unless there are academic problems or really significant social problems, a lot of times maybe only a parent would notice the change. And then autism is also in the differential. Both conditions include a seeming indifference to companionship with others. However, autism spectrum disorders can be differentiated by stereotyped behaviors and interests. So that's schizoid personality disorder. Please stay tuned for part 2, schizotypal personality disorder. Even more interesting.